We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Good afternoon, everyone. Welcome to today's work in progress session. Before we start, I'd like to respectfully acknowledge that I live and work on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, Solo, and Tsleil-Waututh nations. I am pleased to present to you our speaker today, who is Jacob Hutton. Jacob is a PhD candidate in the experimental medicine program at the UBC Faculty of Medicine and a researcher in the BC Resuscitation Research Unit at Providence Research, and also a paramedic with the BC Emergency Health Services. I've had the pleasure of seeing Jacob in the last 4 years, did a lot of amazing work in this area. So I'm pleased to see him present some of his work today. His research interests include technology innovation to transform the response to life-threatening emergencies such as cardiac arrest and trauma in community settings. He is currently involved in leading research efforts to harness consumer wearables for cardiac arrest detection and prediction. Outside of this work, Jacob can be found skiing, running, or mountain biking in the coast mountains surrounding Vancouver. So without further delay, please join me in welcoming Jacob as a speaker in today's work in progress session. Go ahead, Jacob.
Thank you, Joseph, for the great introduction. Yes, so I'm happy to be here today to talk for about 40 minutes on some of the work that we've been doing around trying to improve survival from cardiac arrest with consumer smartwatches, and particularly some of our work that's been focused on end-of-life studies and trying to collect data at the end of life with consumer smartwatches, and then apply that to solve this problem of cardiac arrest, or at least a piece of it. So, as Joseph mentioned, I'm based at UBC in the Department of Emergency Medicine, and more specifically, I'm with a group that's housed in Providence Research called the BC Resuscitation Research Collaborative. And within that group, we have a biosensor team, which is a multidisciplinary technology-focused team focused on trying to develop hardware and software for consumer wearable-based cardiac arrest detection. And our key focus is on unwitnessed cardiac arrest, when no one's around to see the onset of a cardiac arrest. My background, as mentioned in the intro, is as a paramedic, and as paramedics, cardiac arrest is the most time-sensitive critical emergency that we respond to. And if we're able to get there sooner, the idea is that we would be able to hopefully have a better chance of successfully resuscitating a patient after cardiac arrest. So that's the overall goal. And some of our work's been profiled in publications like the Advancing Health Outcomes publication. We had a story a few years ago about some of our earlier work, and I'm here today to give an update. So the overall problem and disease area that we're focused on is the problem of sudden cardiac arrest, and that's a pretty big problem. So globally, it occurs with an incidence of about 100 per 100,000 cases. In Canada, on a yearly basis, we'll have about 60,000 individuals have a sudden cardiac arrest in an out-of-hospital setting, and the survival is very low. So overall, about 5 cases will survive to hospital discharge, and sudden cardiac arrest is highly time-sensitive because the heart has lost the ability to circulate blood to the critical organs of the body, including the brain. These patients lose consciousness almost immediately, and sudden cardiac arrest requires prompt interventions such as CPR and the application of an automated external defibrillator to try and reverse cardiac arrest and restore the heart's ability to pump blood. And usually if we can get there within the first 10 minutes after cardiac arrest, that's when the patient has their best chance of survival. And that's sort of what this project is trying to address, is trying to get to these cases sooner. So the current state of unwitnessed cardiac arrest is that this is occurring in the community, and many who have unwitnessed cardiac arrest, they may either own a consumer wearable device, or maybe part of the population who would be maybe willing to own a consumer wearable device. And although those consumer wearable devices, and I'm talking about smartwatches, smart rings, things of that nature, although these technologies can tell us some information about physiology, they can give a heart rate, they can tell you how many steps you walked in a day, they don't really have the capability to detect an emergency and alert authorities. And we're sort of getting there, but it's slow progress. So really today in Canada, it's still dependent on luck, whether or not these cases will receive assistance or die alone. And so for us as a research program, we wanted to take this on and formed a couple of research program objectives around this. So number one, we wanted to understand the population of unwitnessed cardiac arrest and how we might be able to impact survival through increasing detection and moving those unwitnessed cases into more of a witness category. And to do that, we wanted to develop validated, trustworthy, and scalable systems for detecting cardiac arrest in the community with everyday devices. There's a couple key things here. So number one, everyday devices, meaning the types of devices that people are already comfortable using, like I mentioned, smartwatch, like rings, not very invasive devices like implantables. So in order to have overall impact for cardiac arrest, we need to have devices that are going to be well tolerated by large amounts of people. So the everyday device is a key point. And these systems have to be trustworthy in order to scale. So a big problem here is the presence of false alerts. And so that's a major area of focus for us, is making sure that when these devices detect cardiac arrest and convey that alert to 911 and to first responders, that first responders can trust that alert, and we're not going to break the system. So to support that validation piece, we wanted to collect real clinical data on cardiac arrest for algorithm development and validation. And then also a sub-objective was to try and see, once we're good at detection, can we actually get ahead of this and look at the feasibility of predicting cardiac arrest with these wearable devices. And for me, this is all under the sort of overall fundamental assumption that wearable devices are out there in the community and are capable of providing much more in-depth monitoring than they currently do. And at some point in the future, will be integrated into healthcare in a more systematic way and be able to provide more impact than they do currently. So this is sort of an objective under that large scale assumption or hypothesis or goal, that in some point in the future, wearable devices will be able to have more impact than they do now. So back to cardiac arrest. The main problem, or one of the main problems, is that half of all cardiac arrests are not treated by paramedics. And so in North America, of the 430,000 cases per year, only approximately 50% of those cases will receive any treatment at all by paramedics in the out-of-hospital setting. The other 50% are cases where paramedics, for some reason, elect to not provide treatment, and that patient is determined dead at the time of paramedic arrival, and there's no resuscitation attempted. And historically, the 50% of patients who do receive treatment have been the focus of most of the research we've done in trying to make our systems more efficient, trying to make our medical interventions more effective. And the 50% of cases that are untreated have not really been investigated as much because we haven't had the technology to really move the needle on their survival. And so there's a large cohort of these cases, about 50% of the over 400,000, that are an untapped area of opportunity to try and increase cardiac arrest survival. So to start getting at the first objective that I outlined a few slides ago, we wanted to analyze why these cases weren't receiving treatment. So we looked into our cardiac arrest registry data in BC. So here at our resuscitation research unit, we collect registry data on every cardiac arrest that occurs in the province. And so we looked at an analysis of untreated cases with obvious death in the years 2019 to 2020. And we found that in over 5,000 cases with obvious death, the vast majority, 86%, were in private locations. And the most common reason for a lack of treatment by paramedics was an assessment that there was too long between the time of onset of cardiac arrest and arrival of paramedics. So a prolonged interval from onset to assessment was the predominant reason for withholding treatment, and that was the case in 80% of these cases. So that sort of outlines that time is a big problem in terms of whether or not a case is going to receive treatment or not. And it's not any other factor relevant to the patient's individual physiology or the cause of the cardiac arrest. It's just this issue of time. So we wanted to extend that and ask the hypothetical question, could technology result in more cases being treated? And so we did another analysis of the same time frame, 2019 to 2020. We looked at all cardiac arrest cases that occurred in the province during that time frame, which was over 11,000 cases. And we found that those that were witnessed by a bystander, so someone was there at the time of onset of cardiac arrest, those cases received treatment 99% of the time. And of that subgroup, 17% survived to hospital discharge. And on the other hand, the unwitnessed cases, which was 75% of the total, only 55% of those cases were treated, and that translated to a much lower survival of 5.4% surviving to hospital discharge. And so we looked at that discrepancy, and we did some modeling work to estimate if cases had been witnessed by a virtual bystander, which we equivocated to the effect of having someone there, but that person not providing any interventions like CPR or putting an AED on. Just the simple fact of having someone there to witness the cardiac arrest and contact 911, we anticipated that survival would have doubled during that time. So that sort of lays out a framework for, potentially if we were able to have that virtual bystander effect provided by technology, there could be a fairly large survival benefit to be had. So then the next question asked was, well, how would we be able to make this happen? And so we did a few different studies to look at the technology and adherence landscape. So number one, we looked out there and we said, what technologies are out there, what systems are out there that can detect cardiac arrest, and how accurate are they, and what are the validation and testing procedures that have been used to assess that? And we found that no technologies existed that had been validated with real cardiac arrest data. We published that paper in Resuscitation Plus. We took it one step further. We did another systematic review and looked at the landscape of consumer wearable technologies that just do any kind of cardiorespiratory monitoring. And we found that common sensors in popular consumer wearables like smartwatches are actually well suited for cardiac arrest detection and can monitor the physiological parameters that you'd want to if you wanted to do cardiac arrest detection. But there's still not really anything out there in either the research landscape or the commercial market. And then to support the idea of whether or not people would be willing to wear these technologies and use them, we also surveyed about 360 people across Canada, and we found that people are willing to wear smartwatches for cardiac arrest detection, and their willingness increases as their perceived risk of cardiac arrest increases. So it seems like there's a state where we have the physical technology, but we haven't done the validation work to make these systems trustworthy and clinically validated. And if we did, people might be able to use these technologies to address this problem of unwitnessed cardiac arrest. And so the main technology that we found in these reviews that is really useful for potentially building into a cardiac arrest detection system are these sensors called PPG sensors. And these are the lights that are on the base of consumer wearables. If you've ever looked at the bottom of an Apple Watch or a Fitbit, you can see these lights flickering. They're non-invasive, low-cost optical sensors, and they can measure lots of different physiological information by looking at the change of blood volume underneath them. And they're very common in consumer wearable products. And so using this reflective PPG, these sensors can estimate blood flow underneath them, and you can use that data to estimate a heart rate. You need to do some filtering and smoothing to clean up the signal, but once you do, you can estimate a heart rate by looking at the amount of peaks per minute underneath the sensor. And you can also derive other metrics such as heart rate variability. So how is the heart rate changing over time in terms of the peak to peak distance? And you can correlate that to all sorts of different autonomic function measures. So these PPG sensors are very useful for physiological monitoring in general. And as a result of these reviews, we thought, well, maybe they'll be useful for cardiac arrest detection. So to validate that hypothesis, we did an experiment at UBC and VGH, where we collected PPG data using a simulated cardiac arrest model. So healthy volunteers at both these sites received a simulated cardiac arrest with a blood pressure cuff. So healthy volunteers would come in, they would put a PPG sensor on their wrist right about where a watch would sit, and a blood pressure cuff was applied to the upper arm and inflated past the point of arterial occlusion, so cutting off the flow of blood distal to the blood pressure cuff. And those segments of data were marked as occlusion, which was a stand-in for the type of pulselessness that would be present if you had a cardiac arrest. And based on that experimental model of simulated cardiac arrest, we trained an algorithm to detect this occlusion, which was published in Nature Scientific Reports last fall, and was able to demonstrate performance to detect that occluded state with an 83% accuracy, and also to distinguish whether or not the device was off body, or if the activity was termed as normal cardiac. So normal cardiac detection accuracy was 93%, and off body was able to be detected at 100% accuracy. So that was a good result for this simulated cardiac arrest model. Healthy volunteers sitting down in a chair, having a blood pressure cuff applied, and then having an induced pulselessness. But there are also significant limitations from this model. So this is not a natural cardiac arrest, so there's no transition from sort of normal state into cardiac arrest as it would happen in a real cardiac arrest. Blood pressure cuff is inflated, the pulse is cut off. So there's no transitory period. And there's also very questionable generalizability. As with lots of university-based research, these volunteers were healthy, they were under controlled laboratory conditions. So we still had this question about, well, how well will this generalize to real cardiac arrest? So to address those limitations, we wanted to go one step further and actually collect real cardiac arrest data. And we did this under the banner of what I call the Notify study. Would have preferred to call it the Detect study, but there's many Detect studies out there. So this is called the Notify study. But this took a multi-site, multi-arm approach to accomplish the goal of collecting cardiac arrest and non-cardiac arrest data using these PPG wearables that also had movement sensors. And we did this across multiple clinical arms. So in each clinical arm, we had the recruitment goals of recruiting 20 to 40 individuals at minimum. And in each of these settings, a patient would be provided with a wearable device that they would wear through the course of their clinical care, and wear it up to the time of death and after the time of death. And then we took that data and paired it to the clinical assessments and used that to try and do some algorithm training. And we had 3 arms for this study. So we started a MAID arm in May 2024, where we provided this watch to consenting patients who were undergoing medically assisted dying procedures. And we did that in Greater Vancouver and Greater Toronto area. We had an ICU arm, which started in July 2024, and that was at VGH, where patients who were having withdrawal of life-sustaining therapy were provided the watch and would wear the watch through that procedure. And then we also had a hospice arm, which was started in May 2024, and in various sites around Vancouver. Patients were recruited once the clinical team thought they would be within about 2 to 4 weeks of death, and they would wear the watch from that time forward. And so that gave us sort of a couple different cohorts to pull data from. And I'm going to go through a couple of the interim results from that data a little later on, but I won't be talking about the ICU data because we've had less recruitment in that arm. So we'll just focus on the MAID arm and the hospice arm for this presentation. Overall, throughout the site, we had a few hypotheses. So number one was that usable data on cardiac arrest and non-cardiac arrest can actually be collected from these populations. These populations aren't commonly researched, and certainly not with technology-based interventions like this. So that was a hypothesis that this would even be a feasible thing to do. And then if that was possible, we also hypothesized that cardiac arrest, the lead up to cardiac arrest, and normal activity could be differentiated reliably using this raw PPG data, and also the derived metrics that you can calculate using PPG data. And then also that using this real cardiac arrest data is actually a better approach than the simulated data approach that I described in the Nature paper, which would actually allow for increased algorithm performance and maybe even some level of predicting clinical deterioration. So the inclusion criteria for this Notify study was very broad. So we included adults who were above 18, who were either admitted to a participating hospice or palliative care unit and expected to die within 2 to 4 weeks, or were receiving a scheduled MAID procedure with a participating MAID clinician. And the patients just had to be willing to wear a steady watch for the duration of their care. The specific watch was a consumer-grade smartwatch called the Actigraph Leap Watch, which is manufactured for this type of use to collect raw data. And this watch collected data leading up to death, at the time of death, and post-death, and would automatically upload that data to the cloud. And we used that data to investigate trends in raw PPG and accelerometry. So accelerometry is movement data. And then also a few derived metrics. So the estimated heart rate, the estimated interbeat interval. So that's the timing between the peaks of blood flow underneath the sensor. And then from the interbeat interval, we can estimate various metrics related to heart rate variability, which is a reasonable marker for autonomic regulation. I'll talk a bit more about that later. We also collected various clinical endpoints. So the primary endpoint was death while wearing the study watch. And we also collected clinical endpoints, secondary endpoints, to define an onset of a transition period. So, and this was different in different cases. So for witnessed hospice deaths, we collected the time of the onset of respiratory arrest. So not all hospice deaths are witnessed. Some happen when no clinician or family is there around to witness that. So for the ones that are witnessed, we were able to get the true time of the onset of respiratory arrest. But for unwitnessed hospice deaths, we collected the time of the discovery of the respiratory arrest, knowing that the true time of respiratory arrest would have been before that time of discovery. And in the MAID arm, we collected the time of the administration of the MAID medication cocktail, which is a cocktail of medications given to result in cardiac arrest, which takes about 6 minutes. And these clinical endpoints and the assessment of death is a bit complicated for this study. So I just wanted to outline that a little bit. when you want to do this kind of work and train machine learning models for detection, you need a ground truth that's called supervised learning, and so you need to know the time of cardiac arrest. And in both of our cohorts, knowing that time is a bit challenging. So we do know a couple things. In the MAID cohort and the hospice cohort, we always have a time of death recorded by the clinician, and that's the final time. But the way that time of death is recorded is somewhat protocolized, meaning that it's not always the true time of cardiac arrest. So in the MAID cohort, as I mentioned earlier, we have this time of MAID medication administration, and that's when we know there's a period of dysregulation and transition to death that is onset at the time of MAID medication administration. But because of the MAID procedures, it takes about 6 minutes to provide this medication, and then the clinician will be hands off of the patient for 5 minutes, and then return in the last minute of the 5 minutes to declare death and record that time. So within that interval, we have the true time of respiratory arrest and the true time of cardiac arrest, which are both unknown. So we have to take this interval approach to defining ground truth as just being somewhere within that interval. In the hospice cohort, it's a little bit different. For the cases where we know the true time of respiratory arrest, we can mark that as a witness case where the time of respiratory arrest is known, but that's only about half the cases. In the other half of the cases, we don't know that time of respiratory arrest. It's unwitnessed. We just know the time of discovery. And in both situations, we have a time of death that's recorded by a clinician and a time of transition or dysregulation that starts at the time of respiratory arrest, whether it's witnessed or unwitnessed. And then the true time of cardiac arrest is also not known because staff aren't monitoring these patients closely. They're not wearing any monitoring equipment. So the true time of cardiac arrest is, again, within that interval. So those are some of the key challenges in this work. So that's the necessary background. And now I'll talk a bit about the preliminary results. So right here, we're looking at the participant flow for the hospice cohort on the left and the MAID cohort on the right. In the hospice cohort, we took the approach to have clinical staff sort of float the idea of participating in the study to patients, and then patients who indicated they were interested would be approached by a research assistant. So we don't know the true number approached for enrollment, but overall, we were able to enroll 38 patients over about a 10-month timeline. 3 withdrew from the study prior to death due to watch band discomfort, and 5 did not wear the watch at the time of death. So that left 30 who met the primary endpoint, and those 30 were available for analysis. In the MAID cohort, we do know the denominator for who was approached for enrollment. So over a 10-month timeline, our clinicians approached 36 patients, and of those 36, 34 patients enrolled. So it's a very high enrollment rate. And 0 withdrew from the study prior to their death, 34 met the primary endpoint, and 34 were available for analysis. So comparing the two cohorts, we see that in terms of age, the cohorts were fairly similar, so about 80 in terms of the average age. The cohorts both skew a little bit more male, but overall it's pretty close to 50-50. The leading diagnosis leading to palliative care or MAID was most often oncologic and hematologic conditions, with non-malignant conditions being the second most common for the hospice cohort and respiratory disease being the second most common for the MAID cohort. In the hospice cohort, 43% of patients had a witnessed death, and 30% did not have a witnessed death. So that speaks back to the point of actually trying to know the true time of cardiac arrest or death. So we only have that really good data for about half the participants in the hospice cohort. In the MAID cohort, all patients had a witnessed death and all died wearing the watch, whereas only 63% of the hospice cohort died wearing the watch. And this is just looking at the cumulative survival over time, just for the hospice arm. The median days from enrollment to death was 14 days. with a very wide range. So the shortest time on study was 1.5 days, but the longest was 86.5 days. And so right here, we're looking on the left at the cumulative survival over time for the entire cohort with those patients who removed the watch prior to death as censored observations. And on the right, we're just looking at the same cumulative survival over time, excluding the one outlier, which was 86 days. And looking at the data from the hospice cohort, we can look at a few different things. So we can plot over time the changes in the raw PPG signal leading up to death. We can also apply various filtering and smoothing techniques to this data and try to count the peaks using industry standard approaches. And through those techniques of counting peaks, we can derive an estimated heart rate. And then we can annotate on all these graphs the time of last breath and the time of death. And then we can investigate changes in the signal in the lead up to cardiac arrest and last breath and at the time of both those clinical occurrences. And so there's lots to see here. We see a lot of variance in the raw data. We see maybe some changes at the time of last breath and the time of death. And then at the very bottom of the graph, we see a bunch of different squiggly lines, which are 3 different approaches to calculating heart rate. And we see that there's quite a wide variance in the estimated heart rate over time. And right here, we're looking at about the 16 hours leading up to the time of death for this patient. And also a heart rate continuing to be calculated after we know the patient has died. So those simple heart rate methods not really being very reliable for detecting cardiac arrest. When we zoom in on the signals right near the time of death and stratify the signals based on the clinical state the patient was in, we can see that the raw data segmented by these clinical timelines shows differences in amplitude and frequency. So in this plot here, we can see the normal cardiac activity at sort of not at the time of death, like many hours before the time of death, being fairly regular, good waveform. When we look at the cardiac activity at the time of last breath and at the time of death, we see a much reduced amplitude and a different frequency for the raw signal, which is a promising foundation for machine learning to try and actually use machine learning methods to detect these differences in the signal amplitude and frequency. So very promising for cardiac arrest detection using these smartwatches. On the prediction side, things are a bit more challenging, but we can look at derived metrics. I mentioned heart rate variability earlier, and here we're looking at 3 different metrics of heart rate variability. So we're looking at the proportion of beat-to-beat intervals that are less or more than the median divided by the total number of beat-to-beat intervals on the left, and then we're looking at the root mean square of successive differences in the middle, and the standard deviation on the right. So these are all just various metrics for estimating heart rate variability, and we see that the red line is the 12 hours prior to respiratory arrest for the average value for the cohort. And the blue is just a random baseline, so not taken on the day of death. And then the gray lines are the individual participant traces. And especially looking at the PNN50, we see that the red line is elevated above the blue line and spikes in the about hour or 2 leading up to death. And maybe some signal in the other 2, although it's not very clear. And when we try and run a statistical analysis, we can see that the HRV, the heart rate variability, is elevated leading up to cardiac arrest. So right here, we're looking at the buckets of time in the hour leading up to respiratory arrest, the average PNN50, which again is just a marker for heart rate variability, which is a measure of parasympathetic activity. And we can see there are changes leading up to respiratory arrest. But what this means is unclear. So more investigation is needed here, but maybe there might be some signal for trying to get a bit of a warning of impending cardiac arrest or respiratory arrest. So that's in the hospice data. This is an example trace from the MAID cohort. So again, we're looking at a similar figure to what we saw earlier. In the top panel, we have raw PPG recordings. In the middle panel, we have processed PPG recordings that are smoothed and filtered to erase movement and light contamination of the data. And then we have various methods to estimate the peaks from which we can derive heart rate. And then in the very bottom panel, we have the estimated heart rate. So the same way a consumer wearable watch would estimate heart rate. And we're looking at about 40 minutes of data here with the time of medication and the time of death annotated. And you can see here that depending on the method that you use to try and calculate heart rate, that either results in a heart rate of 0 or a heart rate that is at 140 a few minutes after death. So depending on the method you use to calculate heart rate, there might be some definite error here, but you can see that there are changes in that transition period between medication and death for both the derived metrics in the bottom panel and the raw data in the top panel. And zooming in on this data again, we can see that the raw data segmented based on the clinical timelines, so normal cardiac activity, the time of last breath, and the time of death. We can see there are differences in amplitude and frequency, which is a promising foundation for machine learning, feeding this into a model and trying to segment that with a machine learning model and predict whether or not cardiac arrest has happened or not. Or I should say detect, not predict. So after a quick analysis of this data, I was feeling great about it. I said, well, are the relationships so strong in this data on the predictive side that we could feed these derived metrics into a very simple machine learning model like XGBoost, which is a classifier, and just predict whether or not death is going to occur within 60 minutes. And so we looked into that using the derived metrics for heart rate variability and just putting that into the model, and at each time predicting a likelihood of death being within 60 minutes or not. And the results are very poor performance. So there's 3 models here, just using various combinations of these heart rate variability metrics. And we can see that the sensitivity is hovering around 50% for the first 2 and is at 0.2% for the last model. So it's not just a simple case of putting these into a model and just predicting death within 60 minutes. More complex and nuanced models are needed to actually incorporate time trends, so changes over time. And so this requires more of a deep learning approach, and we don't have enough data for that yet. So more to come, I think, but it's not just a simple case of feeding this into a model as a classifier. We need to have a model architecture that incorporates time trends and changes over time. And those do exist, but they need a lot more data. So to summarize just a preliminary analysis of that, of the phase 1 of this Notify study, it does appear that the data could be useful for machine learning based detection of cardiac arrest and possibly prediction of cardiac dysfunction in the lead up to death. But the models that would do that require advanced feature engineering and more complex architectures than just your simple classifier model to be useful. On the logistics side of actually running these studies, we found that data collection is possible from both populations with a high opt-in rate. One motivated MAID provider in this study generated more participants than an entire regional program that had more limited resources. So that's an interesting finding for future work and future research in the MAID population. So you really need that institutional buy-in. And the hospice studies are quite resource intensive. And so I think on average, we were having an RA visit these sites about 4 to 5 hours per week. And as I mentioned earlier, the data quality and the ground truth, knowing the actual time of cardiac arrest is a lingering challenge here. So those are sort of the learnings from the first 10 months. And I also just wanted to talk briefly about the reasons for participating. So a few months into the study, we started providing the participants the opportunity to note their reasons for participation. And we found in general that there's a strong sense of helping science, giving back, providing some value at the end of life, and contributing to medicine and the care of patients. So I think that also informs maybe future research in the palliative care setting and in the MAID setting, whether it's technology-based or not. These patients do seem to be interested in participating and maybe speaking to the fact it's giving them a sense of meaning at the end of life, or at least contributing to a sense of meaning. I'll just briefly mention the things we're working on now. We are taking the algorithm that we trained based on the simulated cardiac arrest model with the blood pressure cuff and retraining it using this clinical data that's using a process called transfer learning. And we're also building a system to support live data analysis and alerts for actually deploying a system into clinical settings to try and detect cardiac arrest in real time, which is a limitation of the current model we have because our watches just upload to the cloud once a day. And we're also thinking as well about, well, how would we design a trial to actually do this prospective evaluation and see how accurate these models are when they're actually deployed in a clinical setting. And so this is a picture of our system that we've been working on in parallel with this study that can analyze data in real time and make predictions about cardiac arrest, which will be a great advantage for us compared to our current setup, which is just uploading data passively once a day. And I think our plan for prospective evaluation will be to plug our model into that platform and give participants watches again, like we have, and then run this in real time and see how the predicted time of cardiac arrest actually aligns with the recorded time of cardiac arrest in these clinical settings. So I'll just quickly mention as well, the elephant in the room is that in February, Google published a very similar piece of work in Nature called Automated Loss of Pulse Detection on a Consumer Smartwatch. And when we first saw this, we thought, oh man, they ate our lunch. But looking a bit more into the study, we find that the approach they took is very similar to our approach with the simulated cardiac arrest. So this is the flowchart of their experimental procedure on the right here. But I'll just tell you that their main model for cardiac arrest was actually peripheral arterial occlusion using a blood pressure cuff in the same way that we did in our earlier paper. And we know this is a decent model for cardiac arrest, but it doesn't translate well into clinical populations. So we'll see if that's a barrier for them in making real world impact. The published sensitivity of this approach was 67%. And when we applied our approach to our clinical data, we saw about a 20% drop in sensitivity. So it'll be interesting to see if they keep developing that and test it on real clinical data. But I will also note they were able to obtain FDA approval for this model just with this simulated data, not testing on any real cardiac arrest cases. So it's hard to say if they're going to keep going down this road to actually test on clinical cases. But that's sort of the main other effort going on right now. I'll just end with some future questions that I'm thinking about currently, and if anyone has any thoughts on this, I'd love to hear them. But certainly, the generalizability of models trained in a hospice setting or using data from a hospice setting and MAID setting, generalizing that into a community setting, which is, again, as I mentioned at the beginning of this presentation, that's the problem we're trying to solve, is cardiac arrest in the community. So will patients in the out-of-hospital setting be similar enough in terms of the onset of cardiac arrest and how it looks to a smartwatch to actually benefit from this work, or are these just two different patient populations? As well, what's the best framework to actually assess real-world impact of these solutions while balancing the risk of false alerts? So false alerts to the 911 system is a huge problem. And you have to make trade-offs in terms of your false positive rate and your true positive rate. It's always a trade-off. So how to set that balance is a key consideration and an ongoing area that we're looking into. And then as well, anything based on this consumer smartwatch model brings up privacy and data security considerations. So trying to incorporate that into whatever solution we would try and deploy at some point in the future is quite important. So very quickly, I'll just acknowledge that that this work was supported by MyTax, CanNet, the BC Ministry of Health, Vancouver Coastal Health Research Institute, and the Transform Heart Failure Strategic Initiative. And I'll also recognize that this work is done by a large team over several sites within UBC, including the Department of Biomedical Engineering, and our hospice work would not be possible without the dedication of our research assistants. So acknowledge their work as well as the patients, families, and staff who have been involved across these sites and participated in these studies. So thank you very much. I hope that was somewhat informative. And if we have any questions or comments for discussion, I'd be happy to hear them.